We are entering into a new zone on ILD due to unknown causes. A lot of ILDs are due to unknown causes only, but these ILDs we don't have any idea about. One of the important ILDs that we do not have really any idea about is sarcoidosis. And sarcoidosis is also important for one particular fact that this is a granulomatous ILD. So that's what I'm going to take. This is a granulomatous ILD. Even though a few ILDs may show granulomas in biopsy, but whenever they talk about a granulomatous ILD, the first thing that should come into your mind is always sarcoidosis, because this is typically going to show granulomas everywhere in the body, and they will be typically non-caseating granulomas, which we will discuss further in this particular video. So before going into the core depth of sarcoidosis, you have to understand one fact, that this is completely an idiopathic disease, which means we don't have any idea about why this disease is happening. Even though there are certain postulates of what could be the probable reasons, one of the important candidates for that is TB, because you see granulomas in both. But that doesn't mean that TB is the reason for getting sarcoidosis, even though they thought it's a different immune response to TB antigen, one causing characteristic caseous necrosis and second causing non-caseating granulomas. But anyway, right now, this has been disproved by a lot of researchers, but still TB holds a very important part of a probable pathophysiological aspect of sarcoidosis. Then maybe some environmental pollutants like silicon and beryllium, because beryllium and silicon also produces granulomas. Probably that could be the reason why they think that this could be the probable underlying pathophysiology, but again disproved largely. And finally, you have a genetic association called HLA DQB1. So this you have to know for the exams. So these are the three important probable pathophysiological links and genetic links to developing sarcoidosis. But apart from that, still the cause of sarcoidosis remains extremely elusive. Finally, sarcoidosis, despite the pathophysiology which we don't know, it is characterized by one important feature that is called an immune paradox. What do you mean by an immune paradox? Immune paradox means that in the patient with sarcoidosis, the central parts, like inside the body, the immunity will be extremely active. Like for example, there will be immune hyperactivation inside the body. That's what you're going to see in the form of granulomas, where macrophages, histiocytes, lymphocytes, all these things will be extremely active, forming a granulomas everywhere in the body. But peripherally, when you take outside the body, maybe in the skin, they are going to be immune downregulation. That is what we refer to as peripheral energy, which means they don't even respond to common antigens like candida. So in the central areas, that is inside the body, you will see immune hyperactivation, but in the periphery, there will be downregulation or energy. So this is a very important aspect of sarcoidosis. This is called immune paradox. And the reason for peripheral energy, we don't know, but we are thinking in terms that the immune cells are sequestered into the lymph nodes, where they are involved in formation of active granulomas, and they're consumed there, resulting in very little immune cells available for the immune activation in the periphery. So that's the reason why they go for energy in the peripheral areas. So this is what the basics about sarcoidosis. But before going into the clinical features, let us see few more important things. Like first of all, sarcoidosis is a female predominant disease, which is typically seen in the ratio of 2:1. At the same time, in sarcoidosis, the race that is susceptible to the disease is the black race. So blacks are going to be having a high risk of developing sarcoidosis compared to the white population, and especially the African American descent. So they are going to have very high risk of developing sarcoidosis naturally itself. At the same time, age-wise, the sarcoidosis has a bimodal distribution. In the sense, they are going to have two peaks. The first peak you are going to develop in a little bit young to middle age, in the range of 25 to 35 years, and the second peak you will be developing in the middle to older age by approximately 45 to 65 years. So there are two peaks for development of sarcoidosis. Clear? So these are some of the basic things that we have to discuss. Now we'll move on to the clinical features of sarcoidosis. Clinical features. In the clinical features, the most common organ involved is going to be the lung. Obviously, that's why we are discussing this in pulmonary medicine, isn't it? So, what could be the most common presentation of sarcoidosis? Surprisingly, the most common presentation of sarcoidosis is incidental, which means asymptomatic. They are not going to present with any particular issue in the first place. Incidental means how you are going to detect. Patient will be taking chest X-ray for some other reason, not for the reason of suspecting sarcoidosis. And in the chest X-ray, you will be seeing bilateral hilar lymphadenopathy. And then only you start suspecting sarcoidosis. Take a biopsy from these nodes, you're going to see the characteristic non-cacheating granulomas. But please do remember, this bilateral hilar lymphadenopathy is also one of the important exam questions because this is the most common presentation of sarcoidosis of all forms. Clear? Fine. You can equate it because incidental presentation you're going to detect through the bilateral hilar lymphadenopathy only. But so that you can also tell bilateral hilar lymphadenopathy is the most common presentation of sarcoidosis and incidentally most of the times. And if they ask you what is the most common symptom across all forms of sarcoidosis, the most common symptom is going to be dry cough. That is the most common symptom of sarcoidosis. Okay. Let us see some of the other presentations of sarcoidosis. Now we have seen all the incidental presentations. Let us move on to the other presentations. What are the other presentations of sarcoidosis? You have two classic presentations. One is called an acute sarcoidosis and second is a chronic sarcoidosis. Typically, acute sarcoidosis is seen only in 1/3 of the patients, whereas chronic sarcoidosis is the one that is seen in almost 2/3 of the patients, which means acute is rare. Even though it is rare, it's going to have a decent prognosis. Whereas chronic sarcoidosis, even though it's common, it's going to have a little bit of badder prognosis. Remember, the conversion rate from acute to chronic sarcoidosis is very, very, very less. Very less common. You don't have usually a conversion from acute to a chronic sarcoidosis, which means acute sarcoidosis is going to have a high rate of remission. And remission happens spontaneously, even without any need of treatment with steroids. So, since they have a very high rate of remission, that is the reason why conversion to chronic sarcoidosis is extremely common. But they do not have any high rates of remission. In fact, they're going to have a very long course, a very slow and progressive course, and the disease doesn't remit at all. That's why they're having a poor prognosis. Similarly, as the name suggests, acute sarcoidosis, the onset is going to be sudden. Whereas in chronic sarcoidosis, onset is going to be gradual. At the same time, the disease tends to be relentlessly progressive without showing any signs of remission or recovery. Clear? Next, what are the usual features of acute sarcoidosis? So, there are three features that you have to know about acute sarcoidosis. One, they used to develop these constitutional symptoms. Second, they develop these pulmonary symptoms. And third, they are also going to develop extrapulmonary symptoms. Constitutional symptoms in the sense they will develop fever, they can develop malaise, they can develop weight loss, and they can develop loss of appetite, which means loss of appetite, loss of weight, and fever. So these are the usual constitutional symptoms. And pulmonary symptom wise, as I told you, dry cough still remains the most common. Apart from that, they can develop shortness of breath, they can develop chest pain also. But dry cough tends to be the most common. And in extrapulmonary, one of the very classic manifestations is erythema nodosum. But before that, let us write arthritis, typically a polyarthritis most of the time. And second is erythema nodosum. Clear? Erythema nodosum. What do you mean by erythema nodosum? Because erythema nodosum is very, very classic of an acute sarcoidosis. And it is so classic that presence of erythema nodosum itself tells you the patient is going to have a good prognosis. Absence of erythema nodosum is actually a poor prognostic indicator. It's such a good prognostic sign in case of a sarcoidosis. So, okay, what do you mean by erythema nodosum? So, clinically, how they are going to come is in the form of a red and tender nodules. And the site usually will be in the shin of the tibia, in the legs. That's the usual commonest site for erythema nodosum. Very, very common finding in your clinics. So commonly you can see if you're going to look for it. It's a tender nodular lesion. And what you're going to see if you take a biopsy from it. If you take a biopsy, you will see paniculitis. in the subcutaneous fat tissue, which means panniculitis means it's just a fat inflammation. That's what we call panniculitis. This is what the biopsy finding will come. And there are a lot of DDs for erythema nodosum, which means it's not a specific condition for any particular area. So first DD is always infection. Infection, if they ask you the most common infection and the overall most common cause of erythema nodosum in the world is streptococcal infection. Apart from that, of course, it's very important in TB, you can see that in leprosy as well. So these are some of the important infectious DD for erythema nodosum. Apart from that, you can see in sarcoidosis, we have discussed already, especially in acute case of sarcoidosis. Then you can see in some vasculitic conditions like Behçet's. Like Behçet, you can see this erythema nodosum. Then in inflammatory bowel disease, typically in Crohn's disease compared to that of ulcerative colitis, but still in inflammatory bowel disease, you can see erythema nodosum. Then you can see with the use of certain drugs like penicillins, oral contraceptive pills, etc. Or you can see in patients who are suffering from a lymphoma. Or it could be completely idiopathic also. You can write at the last. So these are some of the DDs for erythema nodosum. In that, the most common cause is going to be streptococcal infection only in the world. Clear? TB is very, very common in India. So in TB patients also you can see this erythema nodosum very commonly. Fine. So these are the these are the clinical features of how acute sarcoidosis is going to come. But please do not forget this arthritis and erythema nodosum. At the same time, you have a triad of acute sarcoidosis, which has a different name for it. So this triad contains arthritis, erythema nodosum, and bilateral hilar lymphadenopathy. And this triad is what we refer to as something called a Löfgren syndrome. This is a characteristic triad of acute sarcoidosis. And whenever you see this triad, you can be very, very, very sure. And this triad is going to have an excellent prognosis, which means many times they just remit even without any treatment. Just you need symptomatic management of this arthritis with NSAIDs or some analgesic agents. Apart from that, you don't even need steroids. And many of the cases of Löfgren syndrome will remit spontaneously even without treatment. It's an excellent prognostic disease, Löfgren syndrome. Clear. Now let us move on to the chronic sarcoidosis. Little bit of a bad omen, chronic sarcoidosis. It's not something good to happen to anyone. It's going to kill you slowly but steadily if you don't treat them. So again, the most common organ involved will be the lung, and that's what we're going to see first. So what you're going to see in the pulmonary area. First one, obviously, dry cough again tends to be the most common symptom due to the lung involvement, even in a chronic sarcoidosis. Next, you will be seeing dyspnea, shortness of breath, again quite common. But there are some things you have to know about the nose in sarcoidosis, the classic 5 nose in sarcoidosis, which means these things are extremely rare or it doesn't happen. You can remember, never say ever in medicine, never say never in medicine. I told you many times in the last so many videos. So nose means it doesn't mean it will not happen at all. Very, very, very rare. What are things that are characteristic nose, which means they're exceedingly rare and you can take it as it doesn't happen in sarcoidosis. One is pneumothorax, pleural effusion, adrenal gland involvement, cavity formation or cavitating lesions, or caseation, caseous necrosis. These things will never happen in sarcoidosis. Clear? No pleural effusion, no pneumothorax, no adrenal gland involvement, no caseation and no cavitation. Please see the fact that all these things which I told no in sarcoidosis may be yes in tuberculosis. So that's one important thing you have to understand. So this is really, really important to know. Then apart from the lung involvement, you can see the second involvement I'm going to see in the lymph nodes. Lymph nodes are mostly central. In more than 90% of the cases, your hilar and mediastinal nodes are the ones that are very commonly involved. Only in 40% of the cases, your peripheral nodes will be involved, and the most common peripheral nodes that will be involved will be the axilla and the neck. So these are the areas where you get the nodal involvement very, very commonly. Next, eye involvement. Again, very important in sarcoidosis. Typically, they are going to cause iridocyclitis. They can also cause lacrimal gland enlargement, but That's a very trivial finding, but anyway, they can get this iridocyclitis, that is uveitis, which is very important. In that, which uveitis is more common? Your anterior uveitis will be more common than posterior uveitis. Remember, in Behçet, posterior uveitis will be more common than anterior uveitis, whereas in sarcoidosis, anterior uveitis is more common than posterior uveitis. Similarly, in HLA-B27 related arthritis also, which we'll be discussing in rheumatology, anterior uveitis tends to be extremely common. Posterior uveitis usually does not happen. So, in exam, posterior uveitis cause a rheumatological cause, think about Behçet. Clear? Then, liver involvement is also quite common in sarcoidosis in the form of something called a granulomatous hepatitis. And they can cause a splenomegaly as well. And this granulomas can be seen in even bone marrows also. In very, very rare instances, they can cause bone marrow suppression because of this granulomatous infiltration of the bone marrow. But that and all is in a very, very severe and fulminant disease. But usually they tend to show bone marrow granulomas, but they don't cause that much severity like bone marrow suppression and all. But in severe cases, you might get bone marrow suppression and pancytopenia also because of granulomatous infiltration of the bone marrow. You might get some skin involvement in sarcoidosis. There are two characteristic skin problems that you get with sarcoidosis. One is called this waxy skin papules, and second one is one of pathognomonic lesion for sarcoidosis, that is called lupus pernio. This is a pathognomonic lesion for sarcoidosis, where they are going to have a violaceous, little bit of purple color and pink colored lesion. Most common site is the face. When you take a biopsy from that lesion and see, you will be seeing epithelioid granulomas in the dermis. So these are violaceous and purple lesions, and most commonly they will be seen on the face. Clear? Very pathognomonic for sarcoidosis. Let us see how they are going to look like. This is a picture. This is typical erythema nodosum. You can see this is red tender nodules on the lower limb, especially on the shin. If you take biopsy, you will be seeing just a panicule. It's very typical of erythema nodosum. And you can see here, this is a classic example of a lupus pernio, where you can see this violaceous purple to pink lesion on the face, very commonly. Fine. Remember, lupus vulgaris is for tuberculosis. Discoid lupus erythematosus is for SLE. I mean, not SLE, it's a cutaneous lupus erythematosus, related thing. But leave it. Lupus pernio is for sarcoidosis. But now we are moving on to the other organ involvement, like endocrine and kidney involvement. So, what is the most common feature of involving the endocrine system and the kidney? It is hypercalciuria followed by hypercalcemia. So, why they are getting this hypercalciuria and hypercalcemia in sarcoidosis is because of the excessive production of vitamin D. Who's going to produce this excessive vitamin D? The granulomas itself. For example, if you take this granulomas, obviously you are going to have a lot of macrophages within these granulomas. And any granuloma has a collar of lymphocytes. Sometimes in sarcoidosis, you might not have this collar of lymphocytes. That is called a naked granuloma. We'll see in the histological picture in some time. But this macrophages in the granuloma itself are going to result in this hypercalcium and hypercalciuria. How? Because they tend to have this 1-alpha hydroxylase activity. Because of the 1-alpha hydroxylase activity, they are going to convert this 25-hydroxy cholecalciferol to 125 dihydroxycholecalciferol, which is the active form of vitamin D, also referred to as calcitriol. You know, this 25 hydroxycholecalciferol, we are going to call it as calcidiol. Remember, this is the dietary form of vitamin D. So your lab values test this 25 hydroxycholecalciferol only. That is a sign of a dietary adequacy of vitamin D. Clear? But for the active form of vitamin D, you need to get converted to calcitriol. Remember, this conversion normally happens in the kidney. So normally kidney is the one that possesses this 1-alpha hydroxylase, which converts this 25 hydroxycholecalciferol to 125 dihydroxycholecalciferol. But here the macrophages that is present in the granulomas of sarcoidosis have this excessive 1-alpha hydroxylase activity that is going to form excessive 125 DHCC and calcitriol. This is going to increase the calcium absorption from the intestine, and they're going to cause hypercalcemia and hypercalciuria. So this high urinary calcium may even result in formation of nephrolithiasis, stones in the kidney, and in the worst case scenarios, they can even progress to complete nephrocalcinosis. This nephrocalcinosis can further precipitate distal RT, and it has its close association with distal RT. So sarcoidosis can cause distal renal tubular acidosis also. So our nephrology section will cover extensively on what is the relationship between nephrocalcinosis and distal renal tubular acidosis. Clear? Then we'll move on to the neurological manifestations. Among the neurological manifestations, most common manifestation is going to be on the facial nerve palsy, seventh cranial nerve palsy. Then you can get peripheral neuropathies, you can get seizures also. But I always feel the seventh nerve palsy is very, very important to know. And often it can be bilateral also. Bilateral, I'm not telling it's the most common, it is possible. There could be a bilateral element type of seventh nerve palsy. Remember, this comes under a tetrad of features in a particular syndrome called Hereford-Waldenstrom's disease. So which will others simply called as Hereford syndrome. We will discuss in some time. So what do you mean by Hereford syndrome? So one of the components is the seventh nerve palsy. Very important. Okay. Then you have pituitary involvement. Remember, sarcoidosis is an infiltrative disease because of granuloma formation. It's a granulomatous infiltrative disease. I told you whenever you have an infiltrative disease, you are going to affect posterior pituitary than the anterior pituitary. So whenever you affect the posterior pituitary, the most common feature you're going to get is the diabetes insipidus. Clear? You think about infiltrative lesions, always its posterior pituitary is the first thing that is going to be affected. So sarcoidosis is an infiltrative disease. So it's going to cause diabetes insipidus only, more commonly. So cardiac. Which diabetes insipidus? Because of pituitary involvement, it will result in central diabetes insipidus only, or otherwise referred to as cranial diabetes insipidus. But remember, involvement of the kidney because of this nephrolithiasis and distal RTA, you might even result in a nephrogenic diabetes insipidus also, because sarcoidosis is one condition which can result in a combined cranial or central as well as nephrogenic diabetes insipidus. So be careful. You have to find out what is the diabetes insipidus type that happens due to sarcoidosis, because it's a multisystemic disease. It's not only going to cause a single spectrum of disorders. Cardiac involvement, because of the cardiac involvement, you will result typically in a restrictive cardiomyopathy. And because of the restrictive cardiomyopathy itself can result in a lot of conduction blocks and ventricular tachyarrhythmias like VT. So one of the important causes of sudden death in sarcoidosis patients, extensive cardiac involvement, because of that they might die. So these are some of the features of chronic sarcoidosis which you have seen. Okay, some of the organ involvement in sarcoidosis. Now let us move on to the diagnostic points. How will you diagnose? The first investigation that we do in any sarcoidosis patient is going to be the chest X-ray, because you are going to look out for the parenchymal changes, because the basic common sense, the lung is the most common organ involved in sarcoidosis. So any patient with a suspected sarcoidosis, you have to look for the chest X-ray first. In the chest X-ray, you have a lot of stages of sarcoidosis. This staging system is what we refer to as SCADing staging system for sarcoidosis, where it divides into 4 stages. Stage 0 is called a normal chest X-ray, but let us go from stage 1. Stage 1, you have this bilateral hilar lymphadenopathy. That's the only finding you will see. And this kind of extensive bilateral hilar nodes, bulky nodes, we call them as potato nodes. Clear? So one of the important other feature that you have to know is this stage 1 has a very, very good prognosis, and more than 90% of the stage 1 patients will resolve without any treatment only. And this is the most common chest X-ray presentation in sarcoidosis patients. So these are the points that you have to know about stage 1. Very, very good prognosis. Stage 2 disease. Stage 2 disease, you will see bilateral hilar lymphadenopathy. At the same time, you will see parenchymal infiltrates also. Like you can remember a stage 1 with parenchymal infiltrates. Remember, only 50% of these kind of patients will have spontaneous improvement. Remaining 50% may or may not improve. Clear? So, the spontaneous remission rates will decrease in stage 2. When you come to stage 3, here you won't see any lymphadenopathy at all. There is no hilar lymphadenopathy in the first place. But what you are seeing is only parenchymal infiltrates, only parenchymal involvement. Only parenchymal involvement. So this is a little bit more severe stage and itself indicates a poor prognosis. In this condition, you can see miliary transformation. This X-ray is showing miliary transformation, which means sarcoidosis may resemble a miliary TB also. So you have to be very, very careful because the treatment for this is steroids. Whereas in miliary TB, if you give steroids, the patient will die. Obviously, we will give as a cover to reduce the inflammation and high risk, but along with ATT only. Suppose if you need it in HIV patients. But apart from that, steroids alone never form a part of treatment of a miliary TB. So don't worry about that. So anyways, so no hilar lymphadenopathy here, only parenchymal involvement, pure parenchymal involvement, infiltrates or miliary pattern, whatever you want, you can see. But remember, only 20% of these patients will have spontaneous remission, which means it's very, very, very less. And again, a poor prognostic state. Stage 4 is much worse. We'll start seeing extensive fibrotic changes with architectural distortion. Fibrosis means itself it is architectural distortion. This is stage 4 and it's an irreversible stage. You can't reverse. This is definitely an extremely worse prognostic state, not a reversible one. And the patient has to be managed only symptomatically. There's no role for any extensive treatment in these patients because already they have gone to the irreversible stage. These are the 4 stages in sarcoidosis. In X-ray, remember stage 1 only lymphadenopathy, stage 2 lymphadenopathy with infiltrates, stage 3 only infiltrates without any lymphadenopathy, stage 4 extensive fibrosis. Stage 0 is normal. But for diagnosis of sarcoidosis, you need a biopsy for sure. So you are going to do a biopsy. In the biopsy, what are you going to see typically? So I'm going to see typically a non-caseating granuloma. Non-caseating granuloma, which means whenever I see a granuloma, it's going to contain multinucleated giant cells. Yes. Along with that, I will see a non-caseating granuloma. So this is the most important point. Where I take biopsy commonly from, I'll be taking biopsy commonly from a lymph node. So that is where the sarcoid lesions are. That is where you're going to see the sarcoid lesion. So lymph node is one of the best sites for taking a biopsy from. Okay. What are the DDs for granulomatous disease? Some of the DDs for granulomatous disease you can divide into caseating granulomas and non-caseating granulomas. Caseating means TB histoplasma. This is what you have to remember. For example, everyone knows TB, remember histoplasma also. These are going to form caseating granulomas. Non-caseating, typically first diagnosis, always sarcoidosis in exam. Apart from that, you can see in a lot of pneumoconiosis. Especially I told you 2 conditions, isn't it? In the beginning itself, silicosis and berylliosis, silicon and beryllium. Very important. They also cause non-caseating granulomas, but with special regards to beryllium. Then in certain lymphomas, you can see non-caseating granulomas. Then in some hypersensitivity pneumonitis cases. Because if you remember the previous chapter on hypersensitivity pneumonitis, in the biopsy I would have told loose granulomas. These are non-caseating only. They are not caseating granulomas. So in hypersensitivity pneumonitis, you can see. Then vaginous granulomatosis. Because here also you will see granulomas, and many vasculitis also produces granulomas. So some list I am telling you, important list, but apart from that many other conditions may show this non-caseating granuloma. So which means seeing the non-caseating granuloma is not very typical of a sarcoidosis. And many times I told you your granuloma will be surrounded by a collar of lymphocytes. In sarcoidosis, not all the granulomas, but few granulomas in the sarcoidosis patients may not have this lymphocyte collar, and that's what we refer to as a naked granuloma, which is very typical of a sarcoidosis. Then, how will you select which node to be targeted for biopsy? So, in general, it's better to select the active nodes rather than inactive nodes. How will you know whether it's active or inactive nodes? That is why currently this FDG PET is having a very big role for selecting the nodes for biopsy. So whenever the uptake is more, which means that node is going to be very active immunologically, and you will get finding in a very high positive predictive value. So that is the reason why we select the nodes based on FDG PET uptake. So it's a very important investigation. And how will you biopsy the nodes? I told you are biopsying. Many of the nodes are going to be mediastinal hilar nodes only. So how to biopsy? Generally by EBUS guided biopsy, which means this is called endobronchial ultrasound. This increases the yield, that's why. Then just a conventional bronchoscopy and biopsy will have a little bit of lower yield and target may be a little different, and you might not take from the exact target you're intended to. When you're doing with the EBUS, endobronchial ultrasound, you can see the lymph node to an extent very nicely, and the target may be properly reached. So that is why EBS guided biopsies have a more yield and more sensitivity compared to the conventional traditional bronchoscopic biopsy. Clear? So fine. So whenever you have certain particular clinical features, some special clinical features that doesn't warrant biopsy at all. There are some syndromic features are there. There are 3 syndromic features and 3 important areas where you don't even need a biopsy. Straight away you can diagnose sarcoidosis. First condition in a patient with asymptomatic bilateral hilar lymphadenopathy. Plus the patient should not have no fever or weight loss or night sweats or malaise, any other symptom, which means the patient should be purely asymptomatic. Only finding the patient will have is this bilateral hilar lymphadenopathy, potato nodes. This condition can be left alone because they have a very, very high rates of remission. Almost 90 to 95% of these cases will have spontaneous remission. So no need to poke the disease unnecessarily. Clear? Leave it. At the same time, this must be the fact, because if you have fever, weight loss, night sweats and all, it could be lymphoma also, it could be TB also, you never know. So you have to take a biopsy. But if there is no symptoms at all, patient is absolutely well and all right, just leave them. Just wait for remission. Second is your characteristic syndromes. What are the syndromes? One is the Lofgren syndrome, which I already told you. The triad we have seen already, I'm not going to write again. It's a triad of arthritis, erythema nodosum and bilateral hilar lymphadenopathy. Just treat with NSAIDs as much as possible. No need to even treat with steroids. They do go for spontaneous remission. Then is Hereford syndrome. HWR FORDT. Hereford's syndrome, otherwise called as Hereford's Waldenstrom disease. So it's a tetrad of conditions, also referred to as uveo-parotid fever, and it's going to be a tetrad of findings. One is uveitis, typically anteuveitis is very, very common than postuveitis. Then they're going to have parotitis and parotid enlargement. They'll have fever and they have facial nerve palsy. This facial nerve palsy can be unilateral or it can be bilateral also. This is what we refer to as Hereford syndrome or Hereford's Waldenstrom syndrome. And this is a form of chronic sarcoidosis only. Whereas Lofgren syndrome, I told you, is a form of acute sarcoidosis where you don't even need a steroids. Whereas since this is a form of chronic sarcoidosis, you definitely need steroid treatment. Immunosuppressants are mandatory here because they have organ involvement. You can see in the form of cranopalsy and all, anteuveitis, eye is involved. So this is not something taken to be very benign. So you have to treat this uveo-parotid fever. So these are syndromic associations. If you have all these syndromic associations, the idea is, again, you don't need a biopsy. You just can straight away diagnose this as sarcoidosis. So this is clinically based. You don't even need a biopsy. What are the other histopathological changes that are characteristic for sarcoidosis, but generally they are non-specific? First one, you have something called Schaumann bodies. I'll show you what are they. So they will be seen inside this Langerhans giant cell. These are calcium and protein inclusions. You will see inside the Langerhans giant cells. Schaumann bodies. Second one, you have asteroid bodies. These are again small intracytoplasmic, eosinophilic and star-shaped or stellate-shaped inclusions. So this is asteroid bodies. I'll show you in some time. Third one, you have Hamasaki Wiesenberg bodies. Clear? These are past positive inclusions inside the granuloma, inside the epithelioid cells itself, inside the granuloma multinucleated cells itself. You are going to see this inclusion bodies. Let us see what are the inclusion bodies here. These are the biopsy findings. You can see this is a typical example of a granuloma. This is how it's going to look like. And a non-casseating. You don't see any caseous material in the center. So, this is a non-casseating granuloma, and very well they are having a color of lymphocytes. If you see here, this granuloma in the 5 o'clock position, here you can see this is a granuloma here once again. But what you are seeing is there is no color of lymphocytes here. You can see that there is no color of lymphocytes, where or very little lymphocyte is sprinkled around the granuloma. So, this is what we refer to as a naked granuloma. Clear? Then, this is a typical example of a Schaumann body. I told you Schaumann body, this is the Schaumann body. Schaumann body is a calcium and protein inclusion that is seen within the Langerhans cell. Clear? So, you can see this is a Langerhans cell because the nuclei is arranged peripheral. You can see this is the nuclei of the Jane cell. You can see the nucleus is arranged in the periphery. So, this is definitely Langerhans cell. Inside the Langerhans cell, you can see this kind of Schaumann bodies. And this is an asteroid body. Asteroid body. You can see these are stellate shaped eosinophilic inclusions, and these are seen within the granulomas itself. Again, this is an asteroid body. And this is what we refer to as Hamasaki Wiesenberg body. Again, this will be seen inside the granuloma only. You can see this kind of past positive inclusions. These could be large lysosomes containing this particular pigment called hemolipofusin. So, this is what is said to be the reason for this formation of these bodies, that is called Hamasaki-Wiesenberg bodies. Even though these bodies are traditionally described, but they are neither specific or non-specific for diagnosis of sarcoidosis. Clear? So, you have to take it in a very cautious way. This is only for the exams. Granulomas, Schaumann bodies, asteroid bodies, and Hamasaki-Wiesenberg bodies. These are some of the important biopsy findings. Then other investigatory points that you have to know is about the serum angiotensin converting enzyme levels. It tends to be elevated in patients with sarcoidosis. Almost sensitivity is typically around 60 to 90%. That too if you do in active disease. But if you do in inactive disease, like I don't think the sensitivity will be that much. Even 30-35% is said by certain trials, but sensitivity is very poor overall. And specificity is even more poor, only 80% specificity, which means it can be seen in many other conditions also. What are the DDs where serum AC may be elevated? In all the granulomatous disorders, DD wise, in all the granulomatous disorders I mentioned above, like silicosis, berylliosis, then hypersensitive pneumonitis, so many conditions are there. In granulomatous disease, your serum AC may be elevated. So, it's non-specific quite. But where it is not elevated is in non-granulomatous conditions. In non-granulomatous disorders, serum AC will be normal only. So, especially best example is lung cancer. If they ask in lung cancer whether you see elevated AC or not, no, you won't have elevated AC in a lung cancer because it's nothing related to granulomatous lesion. So, granulomatous disorders, serum AC may be elevated. Best example is sarcoidosis. Sensitivity only 60 to 80%, not that great, especially only in active disease that too. Then is serum calcium. Serum calcium elevation is one of the diagnostic points as per many textbooks, but remember again sensitivity is only 10%, which means only in 10% of the cases the serum calcium is elevated. But one important thing is if serum calcium is elevated, it indicates a poor prognosis. It's very bad. But it's elevated only in approximately 10% of the cases, which means you're not going to see in almost 80 to 90% of the cases. Next, you have an outdated skin test that's called a Quame's test. During my MLE exam, this test is supposed to be very commonly asked in 2002, 3 and all. But during that time itself, this was supposed to be an outdated test. But they do ask, but right now, they don't even ask this Quame's test, but just for knowledge purpose, I'm telling you. So, what do you mean by Quame's test? you're going to take a part of the spleen from a patient who's infected, or who's affected with sarcoidosis. A patient who's known to have a sarcoidosis, you take splenic material, not like exact spleen, some part of the splenic material you take and put as an injection on the skin in a patient who's suspected to have a sarcoidosis. But if you see a reaction in this patient, it means the patient is having a sarcoidosis. Clear? So this is what we refer to as a Queen's test. But actually it's a quite specific test. Clear? But again, it's a very not a good procedure to do. At the same time, it's associated with the risk of getting infection from other patients also. So this test is completely outdated now. So what you generally do, let me tell once again, a part of the spleen from a known case of sarcoidosis, some crushed part of the spleen will be injected into the skin of a patient who is suspected to have sarcoidosis. Suspected sarcoidosis patient. So when we call it's a positive test, the test is called positive if you develop this characteristic non-casseting granulomas. From the reaction, if you take a biopsy, you will see this characteristic non-casseting granulomas within 4 to 6 weeks. In 4 to 6 weeks, if you see this non-casseting granulomas, this test is supposed to be positive. This is what we refer to as Queen's test. Anyway, outdated test. You have to completely know this fact. Then, other important investigations, some radiological investigations are there that we might be needing to know. Some radiological signs in sarcoidosis. In chest X-ray, what signs you will see? In gallium-67, but currently this is replaced by PET-CT scans, what you are going to see in gallium-67 and PET-CT scans. Then in HRCT, what are the findings you are going to see? Some important named signs that you see in chest X-ray is what we refer to as something called a Garland sign. Other name for this Garland sign is 1, 2, 3 sign, or you can call it as pawnbroker sign also. Pawnbroker sign. So what do you mean by this Garland sign, 1, 2, 3 sign or pawnbroker sign? Very simple. You have a trachea, bronchus, and you have the lung here. And if you have enlargement of this pretracheal nodes and right hilar, left hilar nodes. So this is what we refer to as 1, 2, 3 sign or Garland sign or pawnbroker sign. Enlargement of right paratracheal, right hilar and left hilar or bilateral hilar nodes. So you can call that way. So this is what we refer to as 1, 2, 3 sign. In gallium-67 or PET-CT scans, gallium-67 is an old scan. Nowadays we don't do that. Instead we do a PET-CT only in the recent era. So what are the findings in gallium-67 or PET-CT scans? The same 1, 2, 3 sign, if you translate into increased uptake in those areas in gallium-67 or PET-CT scan. So that sign we are going to call it as a lambda sign, which means it's a very similar sign. So in these areas, the right paratracheal, right hilar and left hilar, you will see increased uptake of gallium-67 or FDG molecules. So this is what we refer to as a lambda sign. The same thing you can translate to gallium-67 scan. Application is same, but the names are different, that's all. Second one, you have something called a panda sign. So what do you mean by panda sign? When you have a face, you have eyes, and you have ears, nose and the mouth, isn't it? So if you have increased uptake around the eyes because of high lacrimal gland uptake, increased uptake around the eyes, and in the parotid glands, if you have increased uptake near the parotid glands, that is near the ears, near the parotid glands. So this is what we refer to as panda sign, because panda has dark circles around the eyes and the ears. Clear? So that's what we call it as a panda sign. Increased uptake of gallium-67 or FDG molecules in the lacrimal glands and in the parotid glands because of lacrimal gland involvement and parotitis. So this is what we refer to as panda sign. So these are the two signs you have to know in the PET scans and the gallium-67 scans. And HRCT, you can see two characteristic signs. One is sarcoid galaxy sign. Clear? So which means there will be a macronodule in the center that will be surrounded by multiple micronodules like a galaxy cluster. So this is what we refer to as sarcoid galaxy sign. Then you have a sarcoid cluster sign. So where there will be multiple clusters of micronodules but in the perilymphatic distribution. Clear? We have already seen in the basics of the ILD itself this particular point. This perilymphatic distribution of nodules is very characteristic of sarcoidosis, especially if you have a perilymphatic nodule with extensive lymphadenopathy. Like you diagnose sarcoidosis most of the time. Even though closed DDs, TB also can produce this kind of findings, but generally this perilymphatic nodular distribution of nodules and with extensive hilar mediastinal nodes and all, we always think about sarcoidosis as the first possibility. Anyway, so there are two signs are there: sarcoid cluster, sarcoid galaxy. Cluster means you see a cluster of micronodules in the perilymphatic distribution. Galaxy means you have macronodule with surrounding multiple satellite micronodules. So this is what we call the galaxy sign. So these are the two signs that you have to know for sarcoidosis in HRCT. Now we can move on and we can see the classic signs which I have described in sarcoidosis. One, you can see this is the typical enlarged right paratracheal nodes. I'll put in pink. Right paratracheal nodes enlarged, right hilar, left hilar nodes enlarged. So this is the typical 1, 2, 3 sign. If you translate the same sign into Gallium 6-7 scan, you can see this characteristic lambda sign. Enlargement of the right increased uptake in the right paratracheal, right hilar and left hilar nodes. And you can see this increased uptake around the eyes and near the ears because of parotid and lacrimal gland involvement. This is what we refer to as panda sign. Clear? And this one is typically supposed to be the galaxy sign. You can see formation of a coagulant mass like structure. It looks like a consolidation. No, actually it's like a nodular transformation where you can see a macronodule and surrounding, these are macronodules, and surrounding you can see a lot of micronodules. So this and form a coalescent mass, like everything has a mass like lesion together. So this is what we refer to as sarcoid galaxy sign. You can see, like in the center you have a macronodule-like appearance, and as the surrounding, if you move, they become discrete. So micronodule-like arrangement. So this is what we call the characteristic galaxy here. So this is what we call as a sarcoid galaxy sign. And you have a sarcoid cluster sign here, where you can see this multiple micronodules. These are all micronodules that are, you can see, this is a perilymphatic distribution of all these micronodules. They form a individual coalescent mass-like appearance. So this is what we refer to as a sarcoid cluster sign. You can see here, you can see here, here, you can see here, you can see here. All these things are examples of sarcoid cluster sign, where you're going to see perilymphatic distribution of nodules. Clear? At the same time, you have to remember sarcoidosis is a great mimicker, and we always call sarcoidosis as a chameleon because it can mimic anything and you can mimic everything. This is a rule. You have to know this very, very carefully. It's a great mimicker and it's a great chameleon. It can mimic anything and it can mimic everything. Every single presentation in HRCT can be produced by sarcoidosis, including miliary presentation. Clear? But very characteristically, in exam, always remember that particular, apart from the name designs which I told you, remember one particular fact, that they're going to produce this perilymphatic distribution of nodules, with especially when you have this with bilateral lymphadenopathy, please go for sarcoidosis as a first possibility. Very, very characteristic picture of sarcoidosis. Clear? And finally, one more important point that you have to know is sarcoidosis is a disease of exclusion and not inclusion. So with just seeing a non-cascading granulomas doesn't mean the patient is suffering from a sarcoidosis. It's a disease of exclusion. You have to rule out a lot of other disorders unless until they're going to come with classic presentations like typical syndromes which I've described. Otherwise, life is going to be very difficult to diagnose sarcoidosis. It's a disease of exclusion most of the times rather than inclusion. Okay. Treatment. So what is the treatment for sarcoidosis? Treatment wise, the best treatment, if they ask you, and the first line treatment is always steroids. Steroids are form of the major treatment in sarcoidosis, but you have some indications to start steroids. Don't start steroids for all the diseases. Number one, if you have chest X-ray stage 2 or stage 3 disease. Remember, stage 0 normal chest X-ray, stage 1 bilateral hilar lymphadenopathy. Generally, I told you they go for remission usually, so you don't need any steroid treatment. Stage 4 is irreversible stage. Again, there is no point in giving steroids to reverse unless and until you have other indications like second one, extrapulmonary involvement or multi-organ disease. So second indication for steroids. Clear? But chest X-ray stage 2 and stage 3 are typical indications. Stage 4 alone is not an indication unless and until you have a extrapulmonary involvement of disease in sarcoidosis. Clear? So these are the two characteristic indications for steroids. Remember, there are certain things like acute sarcoidosis and isolated bilateral hilar lymphadenopathy. Acute sarcoidosis means, best example is Lofgren syndrome. In these cases, there is no need for steroids. No need for steroids, basically. So, acute sarcoidosis like Lofgren syndrome and isolated asymptomatic, that's very important, isolated asymptomatic bilateral hilar lymphadenopathy doesn't need steroid treatment. I told you this multiple times. These are the only two indications for giving steroids. And suppose if refractory to steroids, the patients are not responding to steroids properly. If it's a poor response to steroids, you can try other immunosuppressants. We generally use azathioprine, methotrexate, hydroxychloroquine. Even some studies tell the efficacy of mycophenolate mofetil also. But anyways, so these are some of the other immunosuppressants you can try in sarcoidosis, but with variable response. But steroids are one of the mainstay of treatment. Remember, in the end stage, which means the sarcoidosis patient is usually going to die of respiratory failure. Simple. Because of lung involvement, that's the usual cause of death in patients with sarcoidosis. In the end stage disease, where you have stage 4 irreversible disease, the only option for these patients is going to be lung transplantation. But generally, we don't do that much for sarcoidosis patients because many of them either they resolve in the early stage itself or they die. But lung transplantation is not a very common procedure done for sarcoidosis patients, but that's the only option if it's a stage 4 lung disease and the patient is going to die because of respiratory failure. Then prognosis. There are certain prognostic factors, good prognostic factors as well as poor prognostic factors. As I told you, acute sarcoidosis itself is a good prognostic sign. And this Lofgren syndrome, which is a part of this acute sarcoidosis, once again is going to be a good prognostic sign. And erythema nodosum, if it's present, I told you multiple times, it's a good prognostic sign. Absence of erythema nodosum is a poor prognostic sign. And if you have a HLA B8 positivity, so this is a good prognostic sign. And you have a chest X-ray stage 0 or stage 1-2 disease. This is a good prognosis. 2 is intermediate, 0 and 1 definitely good prognostic sign. Poor means definitely chest X-ray stage 3 or stage 4 disease, surely poor prognosis. And presence of HLA B13 positivity, poor prognosis. Then absence of erythema nodosum is a poor prognostic sign. Presence of chronic sarcoidosis syndromes like Hereford syndrome is poor prognosis. And presence of chronic sarcoidosis, which means if the symptoms of insidious, especially if it's taking more than 6 months, like chronic sarcoidosis, definitely poor prognosis. Apart from that, extrapulmonary involvement like lupus perineo, splenomegaly, hypercalcemia. That hypercalcemia is a very important point. So all these things, nephrocalcinosis, hypercalciuria, distal RTA, all extrapulmonary involvement cases or multi-organ involvement, definitely a poor prognostic sign. And black race itself, even though it's common in blacks, black race itself is a poor prognostic sign. So these are some of the prognostic indices of sarcoidosis. As I told you before previously, most common cause of death in sarcoidosis patients is going to be respiratory failure only because of extensive lung involvement. That's the most common organ that is involved in sarcoidosis, and that is the one that is going to ultimately fail and cause death in these patients also. Fine. So with this, we have finished the extensive coverage on sarcoidosis. I have not typically described all the radiological findings of sarcoidosis because it will be too much. If there is time, we have a probable separate section in the bonus segment maybe later once we complete all the topics. I'm planning to release some bonus sections where I'm planning to do some CT and chest X-ray related basic discussions also. So right now with this, we'll sign off with sarcoidosis. In the next section, we'll be discussing on idiopathic interstitial pneumonias, which is also a form of ILD due to unknown cause.